for multidisciplinary addiction professionals, part 1 of a 3-part training. And Dr. Broyles will be the first one to speak, so I'm going to turn the training over to her. Okay. Okay, Dr. Broyles, just click on that center screen and we should have your, show your desktop. Okay. Dr. Broyles, go ahead. Just a moment, please. Okay, it looks like we're having a slight technical issue. Dr. Broyles is going to redial in, and it should be working at that point. So please all just hold steady here, and we will get this going. If you can hear me, please go down to the chat section and let me know so we know there aren't any other issues with the audio here. This is Chris.
Chris, I'm here now.
Okay. Okay, good. Well, I can hear you, and that's fine. So I think we are ready to go ahead at this point. Thank you.
Okay, thank you. I want to thank everyone for their patience while we worked out the audio issues. Welcome to the presentation today, Buprenorphine Treatment, a training for multidisciplinary addiction professionals. We really appreciate everyone joining this webinar. We're excited to bring this information to you and to hopefully offer more treatment options for patients that can fit their needs. What I'd like to do is introduce myself and my co-trainer, Dr. Rich Silbert, before we get started, just to briefly give you a sense of our background. Rich, would you like to go first? Christine, I think we may still be having audio issues. Can people hear me? Can you type into chat?
Yeah, I can hear you now. Dr. Silbert, are you still on the phone? Dr. Silbert, if you can hear me, please just hang up and redial, because we're not hearing you at all. Thank you.
Okay, I'll go ahead and introduce myself then. As Christine indicated, I'm Lauren Broyles. I am a research health scientist at the VA in Pittsburgh. I work at the Center for Health Equity Research and Promotion, where my research is focused on nurse-delivered alcohol screening, brief intervention, and referral to treatment for hospitalized patients. My clinical background and my PhD are both in nursing. I worked first as a staff nurse on an infectious disease and HIV unit at the University of Maryland Hospital, and then worked on the substance abuse consultation liaison service there, where we evaluated patients and managed withdrawal from alcohol, opiates, benzodiazepines for patients across the hospital in all kinds of settings, helps arrange methadone treatment or inpatient or outpatient IOP, whatever patients were interested and ready for. So I did do some case management work as well, and then we also did some brief motivational counseling while patients were in the hospital. So I'm really coming to the seminar from both a clinical perspective as well as the research perspective, and I'll say a little bit more about that whole idea of the blending initiative, which is part of the whole package here.
Okay, Lauren, are you able to hear me now?
Yes. Would you like to go ahead and introduce yourself now?
Thanks. Sorry for our technical difficulties, everybody. I'm Rich Silbert. I'm a psychiatrist for a little longer than 30 years, most of it. Has been working in the drug and alcohol co-occurring area, and I have been a practitioner and prescriber for buprenorphine, so I kind of come at you from that angle. And these days I work for community care and watch over so many of the different quality and managed care aspects about drug and alcohol and mental health treatment. Thanks.
Thanks, Rich. So what I'd like to do is go ahead and start the program. As Christine mentioned, this is a three-part series. We're going to be covering six learning modules. Today are just the first two. The goal of Module 1 is to provide the context for the rest of the training, and the material that's contained in this part is designed to really help demystify opioid treatment, give an overview of the problem of opioid addiction in this country, and then set the stage for later modules specifically on medication treatment and buprenorphine specifically. What I'd like to do is go through the first module. I will take breaks where you are free to enter questions, and I'll answer those at that time. As long as we're moving along okay in terms of time, I'd like to take a 5 to 10 minute break in between the two modules so that people can make calls, check email, use the restroom, whatever, and then we'll come back to do Module 2. So as I was describing a little bit earlier with the blend of research and clinical, it's a unique feature of this particular program, which is based on a partnership between the National Institute of Drug Abuse and the Substance Abuse and Mental Health Services Administration. So according to Webster's Dictionary, to blend means combining into an integrated whole and producing ultimately a harmonious effect. This blending initiative with NIDA was developed in 2001, with NIDA representing the research arm and SAMHSA and CSAT, which is the Center for Substance Abuse Treatment, representing the service delivery or the clinical angle. The blending initiative, the partnership between the two, is specifically designed to meld science and practice together to improve substance use disorder treatment. And the primary goal is really to develop methods for disseminating research findings into practice. So many people may have heard that it takes an average of 17 years for research findings to actually be implemented and invested firmly into practice. And the goal of these blending initiatives is to shorten that time and make sure that scientific findings are able to reach the clinical practice community and frontline providers earlier, so that it's available in a usable way for people who are actually treating patients on a day-to-day basis. You can see that the blending team members are a mix of disciplines as well as backgrounds. There are researchers, there are clinicians, and all of these folks had worked together to produce these products for us. These are some of the other additional contributors to the blending team product. What I'd like to start with are some of the goals for this particular training. First, we're going to understand a little bit more about the history of opioid treatment in the United States to give you a context for why buprenorphine is so innovative as a new treatment option. We're also going to understand better some of the changes in the laws and then what that means for buprenorphine in particular. Talk about the different subpopulations in this country who are using opioids, and then talk a little bit about how buprenorphine can benefit and add to the range of options for people who are seeking opioid treatment. What I'd like to do now is do some brief introductions for you. This training is typically delivered in an in-person format. This is the first time that we've done it as a webinar. So in lieu of actually introducing ourselves through the sidebar boxes, what we've done is developed a series of poll questions just to get a sense of who's here, what practice setting you work in, and what your patient population looks like. So Christine, can you launch the first poll, please?
Okay, this first poll has to do with your professional role within your organization. So please click on whichever category pertains to your role in the organization, and we'll see how this pans out. We've already got 58% voting, so let's get some more of you in here. Okay, we're up to 75, 76. This is good. So far, nobody is a university student or faculty. This is 83%, so we'll just close it at this point, 85%. Okay, so I think that's a good one. I'll close this, and then we'll share the results. Dr. Broyles, the results show that 58% of the people listening in are counselors, therapists, social workers, or caseworkers in that category. 6% are in the nurse, nurse practitioner, physician, or physician assistant category. 18% are program or unit administrators. Nobody is a university student or faculty. And 8% we have other. And we've asked them to detail that in the question or chat boxes. So I'll be able to see that and give you that later.
Okay, great. Thank you. Can you launch the second poll also to get a sense of the setting in which folks are currently employed?
Yes. Now, this one asks you what type of setting do you currently work in, whether it's a substance use or psychiatric treatment facility, primary care, inpatient, managed care organization, or other. And again, we ask you to give us the details if you click on the other. All right, we're up to almost 80% at this point. Okay, we've got 85% in here now, so we will close this and then share the results. 66% are substance use or psychiatric treatment facility unit workers, 4% primary care, nobody is in an inpatient medical unit, 14% are managed care, and 16% other.
Okay, and the third question, please, about geographically people's current practice setting.
Yes, let me launch that one. Okay, this is, please note whether you are in a rural, suburban, urban, mixed, or other environment. Okay, we're up to 80% already. Thank you all for voting. This is, these are very good numbers. Okay, I've got 88% responding, and we share those results. 27 are rural, 17 suburban, 31% are urban, and 25% are mixed.
Okay, so a fairly even split.
Yes.
And then the types of clients or patients that people currently serve.
Yes. Okay, this is asking if you serve adults, children, adolescents, or pregnant women. And you can check all that apply here if you have a mixed population. Okay, here we have close to 90% responding. So I am going to close it at this point and share. And we've got 98% of the people working with adults, 47% with children and adolescents, and 49% are pregnant women. So there's a lot of people who have mixed client base.
Mixed populations. Okay, and then the last one regarding, no, I'm sorry, I guess there are two more. The types of substance use issues that people are addressing?
Yes. Okay, we would like to know if you predominantly address clients or patients with opioid use, alcohol, amphetamine, cocaine, crack, and other. And again, you can select all that apply to you. Well, we've already got 100% opioid use. Okay, we're up to 81%. We've been getting 88 or 90, so I'll leave it open a couple more seconds. Okay, this is at 86%. There are 98% work with clients with opioid use, 86% alcohol use, 41 amphetamine, 75% cocaine, and 45% other. And again, please, you can use either the question or the chat box to let us know some of the details here. And the next one is, what is the extent of your professional experience with buprenorphine? Do you want to do this one now?
Yes, please.
Okay. So what is your professional experience with buprenorphine? None or little? You work with clients who are taking it, you prescribe it, or you've attended workshops and other educational sessions about it? Okay, we're up to 85% here. So again, thank you so much for participating. Okay, I'll close this at 90% voting, and these results are now being shown. 32% have little or no experience with buprenorphine. 64% work with patients and clients who are taking it. Nobody here has prescribed it, and 34% have attended other educational sessions about buprenorphine.
Okay, great. Thank you. So that gives me a sense of people's exposure to buprenorphine and just a little bit of the pacing and content for the material. Christine, can you return it to my...
Oh, yes, sorry.
That's okay.
No, wait a minute. Well, is it still showing, is it back to showing your screen?
It's not allowing me to advance. There we go.
Okay.
Okay, thanks. So what I'd like to do is quickly just introduce some of the key participants who helped put this set of materials together. The Center for Substance Abuse Treatment, or CSAT, is part of the Substance Abuse and Mental Health Services Administration, which is SAMHSA, under DHHS, and it was created in October of '92 with a congressional mandate that was explicitly to expand the availability of effective treatment and recovery services for both alcohol and drug problems. Their mission specifically is to improve the lives of individuals and families affected by alcohol and drug abuse by ensuring access to clinically sound, cost-effective addiction treatment that reduces the health and social costs to our communities and then also to the nation. Some of the key features of CSAT's mission are really that the treatment is based in research. It's treatment that is community-based and involves coordinated services, and then also consists of multiple options and modalities so that we can really meet the patient with their particular needs. One of the major vehicles that SAMHSA has for ensuring that the current workforce across all disciplines is appropriately trained is the Addiction Technology Transfer Center Network, and that's the network that IRETA, with sponsoring today's webinar, is a part of. There are 14 regional centers and a national office that make up the whole ATTC network. And their goal is really to identify and advance opportunities for training people in addiction treatment modalities. Their overall vision is really to again, integrate science and education and service delivery. They serve the entire 50 states, the District of Columbia, Puerto Rico, the Virgin Islands, the Pacific Islands, and really have made major strides in developing a workforce that is equipped to manage substance abuse issues. I'm going to take a minute to talk about NIDA, which again is the National Institute on Drug Abuse. They were established in 1974 and in 1992 became a part of the National Institutes of Health. They represent the research arm in this partnership, and it's just important to note that a lot of the recent scientific advances in drug and alcohol treatment have been the direct products of research, and most of that research has been supported by NIDA. Their goal is not only to increase the treatment options for people, but really to further everyone's understanding of how drugs of abuse affect the brain and our behavior. But their other primary goal is to really work to ensure this translation of research findings, that scientific data is readily available to policymakers, practitioners, healthcare providers, and then also the general public. They want to make sure that science, as opposed to ideology or anecdote, really form the foundation for our national drug abuse policies and drug abuse reduction efforts. You may have also heard of something called the CTN. This stands for the Clinical Trials Network. As I had mentioned before, there has been an extreme lag time in terms of translating research findings into clinical practice that frontline providers can use. There has also been the barrier that a lot of new treatments for drug addiction have primarily demonstrated their efficacy in specialized research settings that are highly controlled for any variables, and which really represent, in many cases, restricted patient populations. They don't necessarily represent women, don't represent older adults of the entire age spectrum, or different racial and ethnic groups. So this creates a real problem when you're trying to apply findings about new treatments into community-based treatment settings as opposed to academic medical centers. Within the community is where we see more diversity in patient populations. So to address this problem, NIDA has created this National Clinical Trials Network, and their goals are twofold. The first is to actually conduct studies of pharmacological, behavioral, and integrated interventions to make sure that they're effective across a broad range of populations. But their second goal is to really transfer those research results to physicians, providers, and patients throughout this nationwide system. So the CTN is based, it's comprised of these nodes that are dispersed across the country. Each node has one regional research training center, and then 5 to 10 affiliated community treatment programs. And it's within these community treatment programs where the research actually takes place. So the community treatment programs are chosen to participate in a given research study based on the match that they have with the study questions and the requirements and the populations that they actually serve. So, for example, in buprenorphine studies, a community treatment program might be chosen if they served an opioid-dependent population that was different or unique, or a population that they knew they could recruit into study participation. So I'd like to launch the last poll just to get a sense of what people's thoughts are about buprenorphine and some of the concerns that we hear sometimes. This is going to give me a little bit more of a sense of what your background is and what your current beliefs or exposure to buprenorphine are. So it's nice to see this one follow the previous poll where we had about a third of folks who had had none or very little exposure to buprenorphine, and then about 2/3 of folks who had worked already with patients or clients who were taking it. So Chris, can you launch that poll, please?
Yes, that poll is up here, and we ask you just to click whatever statements here resonate with you or your organization. Is it an exciting new treatment modality? Do you feel it's enabling drugs for patients with opioid dependence? Does it fit into your treatment approach? Do you have concerns about diversion or abuse? And do you feel it's a doctor-managed modality with limited use for other professionals? People are thinking about this one a little more. I can see from the results. Okay. Wow. We've got 87% now. I'll wait for a couple more people to answer, and then we can close it and review the totals here. Okay, it looks like it's sitting at 90%. So we will share the results. And 50% feel that it's an exciting new treatment modality. 22% feel that it might be enabling. 35% says it does fit in with their treatment approach. 61% does have concerns for diversion or abuse. And 17% feel that it's a doctor-managed modality and really limited use for other professionals.
Okay, thank you. I appreciate people's honesty and candor on that. I know that a lot of these issues come up for folks, and especially when people are new to buprenorphine, they're not sure about its fit with their current treatment modality. They have concerns about diversion or abuse, and really question in many cases what their role is within a primarily medication-managed situation. What I'd like to do is just present a couple myths and counter-argument to those myths or misperceptions, just again to sort of jostle up our thinking about buprenorphine. When people are considering becoming part of a network of care that involves buprenorphine treatment, a lot of folks do have to go back and examine their own thinking about opioid addiction in general, and what their thoughts are about pharmacotherapy or medication-assisted treatment in particular. What I'm going to go through are some of the myths or misperceptions that people have in relationship to buprenorphine. So one of the first ones that we hear a lot is that patients are still addicted. What we would like to argue is that addiction is actually the pathologic use of a substance. It may or may not include physical dependence, and that physical dependence is not the same thing as addiction. This is really a concept that we're going to spend some more time on later in the training. But our stance and assertion is that using medication as a component of opioid treatment can help a person to function normally. Another myth we hear is that buprenorphine is just a substitute for heroin or other opioids. And what our stance is that it's a replacement medication, but not simply a substitute. And that's not just an issue of semantics. We're going to get into the pharmacology of the medication, and hopefully that distinction between replacement and substitute will become a little bit more clear. Buprenorphine is a legally prescribed medication, and when it's taken sublingually under medical supervision, it's very safe, and it does allow the person to function normally. It's a controlled substance. It's produced and distributed under close supervision and quality controls, and doesn't have some of the same issues of being an uncontrolled substance that would be obtained on the street. The goal of buprenorphine treatment is to ultimately help the person stop the negative and the compulsive behaviors that are associated with drug use, and then help them to return to leading a normal and functional life. That's ultimately the goal of treatment. So using a medication like buprenorphine is one option and can be an important method for actually helping people achieve that goal. The third myth that we'd like to challenge is that providing medication alone is sufficient treatment for opioid addiction. I am guessing that there are a lot of folks in the audience who would not necessarily agree with that option, but we need to stress, of course, that pills don't teach skills, as they say in the ADD community. Buprenorphine is an important treatment modality or option, but it is only a part of the mosaic of complete treatment. The whole package, of course, has to include other elements as well that help people support their psychosocial functioning, their employment stability, all of their general lifestyle and coping issues. Number 4, patients are still getting high. This is, again, where we're going to get into the pharmacology of buprenorphine a little bit later on and really try to illustrate that the fact is that there's a ceiling effect in terms of the rushing euphoria that patients experience with buprenorphine. When it's taken sublingually, as prescribed, patients feel more stable than when they take heroin or other full opioid agonists. Buprenorphine sits on the same opioid receptors as full opioid agonists, but it binds more tightly, and it's going to occupy them for a much longer period of time. And it has this ceiling effect, which I'll describe a little bit later in Module 2, for the rush experience, so that even at higher doses, patients aren't experiencing that euphoric effect. I would like to stop at this moment to answer any questions that you have before we go into the background on the history of opioid treatment.
Dr. Broyles, I haven't had any questions yet, but I do have a comment. They say, I have had several clients who have been receiving their buprenorphine through physicians who do not treat typical drug and alcohol and are not supervised. And these people are not supervised and told to do whatever they want, including how to take the medication. This concerns me as a clinician.
Yes, I would agree with some of those concerns. I'm going to definitely address those a little bit later when we talk about some of the official requirements for being a licensed buprenorphine provider, and the notion that patients are to have counseling and other treatment modalities available to them. It's both one of the pros and the cons of buprenorphine treatment in that it increases accessibility to patients because they can receive buprenorphine in a primary care practice. However, in the absence of counseling and other supportive therapies, it can leave patients shortchanged with only half of a treatment package. So I'm glad you brought up that point. We will be addressing that a little bit later.
Okay, and that's the only comment or question so far.
Okay. I'll give a couple more seconds if anyone else wants to type anything. Anything coming through, Chris?
While they're typing, if so, can I add just a tiny bit to your comments?
Sure, Rich.
You know, I certainly, again, appreciate the same concerns our audience has about docs who are not particularly savvy or trained in the DNA world, and they did have to, as we'll learn later, get a certain amount of training, but there's certainly going to be some individuals, sad to say, who will abuse the purposes, and one of our fears is that that abuse of the good purposes of buprenorphine could certainly endanger a lot of otherwise very important treatment.
Thank you. And during that time, I've had a couple more, two more questions. Who holds the doctor accountable to proper practices and requirements? We have found that doctors are over-prescribing and prescribing benzos and other drugs that should not be mixed together.
Lauren, do you want to save that for later or start?
No, go ahead, Rich, since you can go ahead and give that clinical perspective.
You know, again, that's a very appropriate question or concern about accountability. Right now, there's always been the possibility that doctors who were waivered and qualified prescribers would have audits. I haven't heard much of that happening. One of the ways that some precautions are now being put into effect would be through the insurance companies or managed care companies, that there's evidence of counseling and evidence of certain things, including lack of other benzodiazepines being required in order to get insurance coverage for the reimbursement for the medication cost. So that's been our main approach at holding folks somewhat accountable and making sure there's minimum standards kept to. It's far from perfect, but that's a big thrust for managed care organizations.
Okay, and I just have one more. Why is the cost so prohibitive?
I'll also take a try at that, and you know, welcome Lauren's thoughts. But certainly, when things are still under patent and copyright, pharmaceutical companies charge much higher than when things are generic, and certainly buprenorphine, when given as Suboxone, is way more expensive than methadone and some other medications. However, if you look overall at the giant cost that either treatment at various levels of care or the costs of medical illness and other kinds of problems that come out of drug addiction, it's looked at as a very modest cost compared to the other consequences and issues that could come of opiate addiction.
I would echo that same approach to looking at the issue, not just looking at the pharmaceutical cost, which definitely can be prohibitive for patients, but really looking at the rehospitalization or readmission or other secondary issues related to substance abuse that can arise from untreated or poorly managed opioid addiction. Thank you. These are great questions and great points.
Yeah, I've
Please
got
keep
two
them
more,
coming.
but do you want to hold them for the next
Yeah, if it's
question
okay, I'd like to move through this next little section and then stop again for questions. So please jot them down if there are things that, that the material jogs for you as we're going through. So I'd like to provide a brief history of opioid treatment, again, just to situate where the country's been and where buprenorphine fits into this entire trajectory. So in 1964, some of you may have already been practicing or may have been new practitioners at that time. That was the year that methadone was approved as the first medical intervention that was approved for the treatment of drug addiction. Until recently, the Controlled Substances Act limited the use of narcotics for addiction treatment only to those opioids that were approved by the FDA for detox or maintenance treatment of addiction. And these, as most of you probably know, could only be dispensed by physicians in programs that were regulated by SAMHSA and by the DEA. And these are what we commonly refer to as methadone treatment programs or opioid treatment programs. There are other medications that have also been shown to be effective in the treatment of opioid addiction, but their use hasn't been widespread. In part, it's due to the failure to adequately inform and train the workforce and transfer that technology to the field. So, for example, we had LAM that was a synthetic opioid, very similar in structure to methadone, but it had a lot of trouble making it into the opioid treatment system. People were already used to using methadone, and the way that LAM was introduced to them was really ineffective. Overall, the goal in developing new medications is not to replace the old ones, but to just increase the availability of different treatment options for people. I'd also like to talk briefly about the Drug Addiction Treatment Act of 2000, which I'm going to call Data 2000. We're going to talk more about it in just a minute, but overall, this is a critical piece of legislation that then paved the way for buprenorphine to be available to people. In 2004, the sale and the distribution of LAM or LAM was discontinued, and this was largely due to its initial withdrawal from the European market in 2001, and then extensive changes that were made to the U.S. packaging inserts in April of 2001. They eventually discontinued it because of the risk of related severe cardiac adverse events, and ultimately they decided that its use, the risks overshadowed the potential benefit. Data 2000, again, is a critical piece of legislation that allowed for the emergence of medications like buprenorphine. It has added additional treatment options for people. It's pivotal to know about because it amended the Controlled Substances Act and allowed qualified physicians, which again I'll say more about in a moment, to prescribe approved narcotic medications from their office setting. So the DEA places all drugs and medications on a schedule, Schedule 3, 4, and 5, for example, and placement is based primarily on the substance's medicinal value, its harmfulness, and its potential for abuse or addiction. Schedule 1 is reserved for the most dangerous drugs that have no recognized medical use, and then at the other end of the spectrum, Schedule 5 is the classification used for the least dangerous drugs. Methadone is Schedule 2. Buprenorphine is actually Schedule 3. So this means that it's considered a safer drug with lower abuse potential compared to methadone. So it's subject to fewer prescribing restrictions than methadone is. As a result, patients who are struggling with opioid addiction can receive treatment in a qualified physician's office instead of an opioid treatment program, making treatment more available and accessible to folks who may not have otherwise received it. Right now, it's important to note that nurse practitioners and PAs are not eligible to prescribe buprenorphine under the terms of Data 2000. There are various initiatives. For example, the International Nurses Society on Addiction is pursuing its stance towards increasing the number of providers and the types of providers that can prescribe buprenorphine, but at this time it is restricted to physicians who must be licensed to practice in his or her state. They have to have the capacity to refer patients for psychosocial treatment. This bullet speaks to the comment that was mentioned a couple moments ago. Psychosocial treatment is supposed to include counseling as well as ancillary services like medical care, employment, education assistance, but there's currently no mandate for patients who are prescribed buprenorphine to receive psychosocial counseling. The fact that a physician has the capacity is really the operative word here to refer a patient for treatment doesn't, of course, mean that they actually will, or that the patient will follow through with the referral. So it's really critical that multidisciplinary addiction professionals, again, the target of this training, be really proactive in developing linkages with their physicians with prescribing physicians in their local areas. And that's going to take initiative on both sides, both the physician side as well as the addiction professional side, to really create those linkages so that it becomes a seamless continuum of care for patients. Initially, prescribers were limited to 30 patients for individual or group practices, but the regulations were changed so that individual physicians, not groups, were limited to 30 patients on buprenorphine for the first year. After gaining a year of experience, providers can then move on and apply to obtain an additional waiver that will allow them to increase their number of patients up to 100. The patient limits don't apply to opioid treatment programs that prescribe buprenorphine, but those programs do have to follow the same regulations as those that are set up for the provision of methadone. I'll take this opportunity here, too, to just briefly mention the waiver process that all physicians must go through before they're able to prescribe buprenorphine. The physician must meet the training requirements or be otherwise, quote-unquote, qualified. They have to complete a waiver notification form and submit it to SAMHSA and CSAT. CSAT then reviews that form, evaluates it, and if they issue an approval, there's a special unique license number that is issued and added to the physician's existing DEA license number. Here are some of the other requirements that physicians must meet. Basically, they need to be board certified in addiction psychiatry or certified by the American Society of Addiction Medicine or the American Osteopathic Association. That's AOA. They have to have served as an investigator in clinical trials, completed one of the 8-hour training courses that are sponsored by ASAM or the American Medical Association, et cetera, or other appropriately designated organizations. Have to have adequate training or experience as determined by their state medical board. And then there's some other criteria that are established through DHHS as well. Prior to 2002, buprenorphine was only available in the United States and in injectable form and was only approved for the use of pain treatment, but also sometimes as an adjunct to anesthesia. The sublingual or under-the-tongue formulations of buprenorphine were approved by the FDA late in 2002, in October, for the treatment of opioid addiction and were made available then by the pharmaceutical company, Reckitt Benckiser, in March of 2003. When the regulations went into effect in 2002, the medication was only approved for prescription in physicians' offices. And office-based use requires that the physician complete the necessary training requirements and secure that waiver. In May of 2003, the modifications were modified, though, so that opioid treatment programs can use buprenorphine as well, but they have to, again, do so under the same regulations as methadone. So you end up with two distinct implementation schemes or strategies for buprenorphine treatment, either office-based therapy or through an opioid treatment program.
Lauren, it's Richie. I'm going to add one bit of just interesting trivia. Before, it was commonly utilized even for medical practice for anesthesia. Veterinarian offices often used Buprenex for procedures on animals.
I had heard that as well. Yes, when I was at University of Maryland Hospital, we had actually, we were using it for medical inpatients for opioid detoxification. It was put in a piggyback drip, 50 cc's of saline, and we had actually published those results. So definitely was in the wings before it actually became approved as a sublingual modality. Basically, what I just wanted to present is this slide. These are the results of a SAMHSA evaluation of Data 2000 that they did starting upon FDA approval of buprenorphine in October of 2002. Basically, the evaluation findings that you can see here in the red are that most prescribing physicians perceived buprenorphine to be effective, particularly for treatment of longer duration. So if you see across the bottom, treatment that is lasting less than or equal to 7 days, 8 to 30 days, or more than 1 month, the longer the patients were on the treatment, the more effective physicians perceived it to be effective. There were a lot of positive treatment outcomes that were observed in patients across a variety of clinical practice settings, and the outcomes were consistent with a lot of the earlier research and clinical trials that found buprenorphine to be effective. So again, just to reiterate, at this point in time, only physicians can prescribe the medication, but the rest of the treatment system really needs to be engaged. Otherwise, we're only serving patients halfway. There are a lot of different facets to effective treatment, and if we really think about all the roles and all the pieces that go into that, there are a lot of points worth mentioning. There is the role of managing the physical withdrawal symptoms. There are roles involved in understanding and managing the behavioral and cognitive changes that people have resulting from their use. There is a role for professionals to help patients achieve long-term changes and prevent relapse, really to maintain that recovery. There are roles to establish ongoing communication between the direct care provider and the community provider to ensure this coordinated continuum of care. And then there's also a role for everyone to really engage in a flexible treatment plan that's going to help patients achieve recovery. The idea is really to encourage patients to abstain from further use while really providing those psychosocial and counseling services that are going to increase the likelihood of them achieving sustained long-term recovery. And so it's really important to stress this last bullet where the flexibility and the quality of the relationships between physicians and community treatment providers and managed care organizations are really important. Even if they are geographically separated, there needs to be at least a common treatment philosophy and goal, and ideally rapid access to one another for exchange of information and care planning. I'm going to, in the interest of time, I'm going to move through this information fairly quickly because I'm assuming that, given that most of you are working in this field currently, you're aware of the epidemic of opioid use and abuse in the U.S. I'm going to move through quickly, but again, I will allow time for questions at the end. As most of you probably know, the rates of heroin use in this country have actually leveled off somewhat. The National Survey on Drug Use and Health gives information to policymakers about the prevalence of substance use in this country, and data from a lot of those NSDUH surveys show that for most age groups, the rates of heroin use have been stable or have at least declined. The exception is for adults 18 to 25, which appear here in the red row, where the 2008 estimate was actually significantly higher than the 2003 estimate, and really indicates the highest rates of usage across adults. The one caveat that I need to make to these statistics as well is that the National Drug Intelligence Center with the Justice Department is concerned that we not become too complacent and assume that these rates of heroin use are kind of leveling off and staying put. The concern is that as people continue to use prescription opiates, it eventually becomes less expensive and easier to obtain heroin as their addictions progress. And so we may see these figures climb higher. Most of you know individuals across the age spectrum use heroin. It's more than 3.8 million people over the age of 12 in this country right now have used it at least once in their lifetime. And while we've been focusing mostly on opioid use among young people, there have actually been there's been a downturn in heroin use among youth. However, we've seen the concomitant rise in the use of prescription opioids. And again, this is highest in 18 to 25-year-olds. During the last half of the 1990s, the annual number of heroin initiates, or new users, rose to a level that had not been seen really since the 1970s. Between 2002 and 2007, the number of heroin users, though, ranged between about 91,000 and 114,000, and for the most part had also plateaued. Again, though, people are seeking opioid treatment for other opioid use, and you can see here that the numbers of individuals using prescription opioids are just staggering, in the millions. We've seen similar statistics from the DAWN network, which tracks emergency department visits related to both heroin and other uses. And you can see here that 1/3 of the non-medical use ED visits have been related to medications that are CNS meds, mostly prescription painkillers and sedatives. And among those, the most frequently mentioned were hydrocodone combinations, oxycodone combinations, and methadone. Among adolescents aged 12 to 17, females are more likely than males to have used used prescription medication, whereas the older males, 18 to 25 and 26 to 34, are more likely to be using. So we do see these age and gender differentials where it tends to be older males and younger females. Okay, just watching my time here, checking. I'll pause here for a couple questions or comments.
Okay. One says, and I think this was referring back to where there were questions about doctors. I run a Suboxone program through an outpatient drug and alcohol office, and the DEA has done a routine visit in which they audited files and policy and procedures specifically for the doctor. So that's a comment there.
Good to know. I will check with my colleague, Dr. Adam Gordon at the VA, who is one of the major prescribers of buprenorphine and part of the VA's buprenorphine implementation. And at the next webinar, I will find and bring some more information about these audits.
Here is a concern. They said, my concern is coordinating care is difficult at times. And they're talking about having the same experience depending on the providers.
And I agree. The coordination of care is such, it's something that's so easy to say, and yet in practice is so difficult to do. There's actually an entire module within this webinar that will be devoted to that later on, so stay tuned. But I agree, it's definitely something that's easier said than done, and the practicalities, the devil is often in the details.
Okay.
Okay.
There are two more. What are the thoughts of Suboxone being short-term versus long-term maintenance as treatment?
We are going to come back to that. In Module 3 when we discuss buprenorphine and what the different ways are that it can be used, and we can also present some of the data about efficacy and decision about a treatment strategy for both of those.
And the last one is, why is it cash only?
Lauren, do you want me to take that one?
Sure.
I don't know where the person in the audience comes from or in what state, but certainly in Pennsylvania that would not be the case. There was a move at one point by certain insurers to require that people failed at methadone prior to consideration of buprenorphine or Suboxone. Most of that was pushed back as kind of a very bad and non-scientific kind of way of doing things, but certainly folks in Pennsylvania, at least, on medical assistance and on either what's called in Pennsylvania health choices can get buprenorphine as a covered entity through their physical health plan. It may not be the case in other states. The cash-only thing also comes up about prescribers or practitioners, that there are folks out there who don't agree to participate in certain types of either medical assistance or insurance plans, and then insist on cash only. But sad to say, that's an entrepreneurial approach rather than a healthcare approach or a best practice kind of approach.
Thank you all for these questions. It's really helpful to get a sense from the field of what the real-life barriers are that you're encountering as you work through your own decisions whether or not to adopt this treatment modality or embrace it fully. So I appreciate, again, everybody's candor in letting us know about some of those barriers. I have about 10 more slides in this module that I'd just like to go through quickly, again, because I think it's, for the most part, relatively familiar content. And now I'd like to stop and take just a 5-minute break before we go into the second module. This section is on what the different treatment admissions are for opioid addiction. So another way to kind of look at the magnitude of a drug problem is to look at the number and the demographics of people who are seeking treatment for particular drugs. And there are some differences between folks who are seeking treatment for heroin abuse and folks who are seeking treatment for opioid abuse. The treatment episode data set, which is called TEDS, is part of SAMHSA's Drug and Alcohol Services Information System, and it's a compilation of data on the demographic and the substance abuse characteristics of admissions to, and more recently, discharges from substance abuse treatment. The key point here is that treatment admissions for other non-heroin opiates are dramatically increasing, and you can see that in the yellow line, whereas those for admissions for heroin have actually declined and remained relatively stable. Basically, between 1997 and 2007, we've seen an increase in admissions for primary opioid abuse, increasing from about 16% to 19%. Additionally, we kind of see the same information here in this slide, which is also from the TEDS data, and we see again that the greater number of treatment admissions are for other opioids, and that this is highest among that early adult age group of 20 to 24-year-olds. There are also some demographic differences with respect to patients who are entering treatment for heroin versus opioids. In 2007, for patients who are entering treatment for heroin abuse, tended to be predominantly male. Just over half were non-Hispanic whites, with some Hispanic and African American populations being served as well. About 2/3 were seeking treatment for their drug use, which was primarily through injection means, and the average age was about 36, and folks were using heroin daily. Additionally, about half of those patients had had at least one prior treatment episode. About 1/3 had had a treatment plan that included medication-assisted opioid therapy. And among the secondary drug use, we saw a predominance of cocaine. In contrast, patients who are entering treatment for opioid abuse, we see fewer males, so 53% versus 68%. We see more whites, 88% versus 53%, more oral versus IV drug use, which again reflects the nature of prescription drug use, and different secondary drug use as well. We're seeing more alcohol use and much less cocaine. So again, this slide kind of summarizes that the admissions for opioid treatment, again, tend to be fewer males, more whites, fewer injection drug users, and fewer who had received medication as part of their treatment plan. All of that indicates that clearly opioid use has been increasing and that a large number of people are seeking treatment for opioids. But the data have also been collected that show that there are more users of heroin than people who are seeking or receiving treatment. And so it raises the question of why are some people not entering treatment? And there are a couple reasons for that. The main four that I'm going to highlight here are that the current treatment system typically, broadly speaking, involves either a medical model, for example, opioid treatment programs, or psychosocial programming. Most, or many, I'll say many, opioid treatment programs don't have large behavioral treatment components, and many psychosocial programs, on the flip side, don't provide adequate medical intervention to help people through the withdrawal process. So we're kind of getting a black and white set of treatment options that aren't necessarily well integrated. Secondly, we also know that, of course, people feel anecdotally that getting off methadone is much more difficult than getting off heroin. And so there is to some extent, a lack of understanding about how methadone should be used, as well as the possibility of illicit use for methadone really contribute to that feeling. And people are afraid, of course, of being labeled or stereotyped based on their addiction. The third reason is that opioid treatment programs have very structured rules that require regular attendance. Programs, as many of you probably know, are open early in the morning and close often by mid-afternoon. And so people who are not able to attend the program or adhere to the rules of the program may not be able to receive the treatment or fully engage to the extent that they need to. And finally, a lot of providers believe that treatment requires abstinence from all drugs, and this has been the primary model. But there are a lot of opioid users who are not able to stop using. They often can't tolerate the withdrawal experience, and even if they can, they may be drawn back into a return to use. And so in these cases, for these patients, using a medication like methadone or buprenorphine to assist them with the withdrawal process or prevent them from going through withdrawal can help them actually engage and participate in treatment and then function more normally. A final factor that people often cite as limiting the availability to treatment access is the NIMBY syndrome, so not in my backyard. Even people who recognize the importance of providing opioid treatment and are otherwise advocates may not want a program opening up in their neighborhood or their part of town. So it makes opening new programs very, very difficult. And all of these can point to the need for additional alternative treatment options, which, as I was mentioning before, are now allowable under Data 2000. Opioid treatment is going to continue to be offered through opioid treatment programs as it has in the past, but Data 2000 allows for treatment to be provided in physician offices and then in that way expands treatment options for people beyond just methadone. So the goal was really to have more patients be willing to seek treatment, more patients have access to treatment, and hopefully reduce some of that stigma by broadening the definition of where you can receive treatment and the geographic location. So to summarize this module right before we take a break, just the key points to keep in mind are that the use of medication can be a component as part of a larger set of treatment modalities to help people achieve their goals and return to a stable life. Data 2000 is the piece of legislation that expands the options for both providers and patients so that opioid treatment can be offered in the general medical setting. We know that opioid addiction affects a large number of people and got a little taste of how those numbers fall out in terms of stratification by age and gender. But a lot of people still aren't seeking treatment, or treatment is not available on demand when they do. So expanding treatment options by offering buprenorphine can ultimately make treatment more attractive to people who may be sitting on the fence in terms of deciding if they're ready, can expand people's practical and logistical access to that treatment, and hopefully reduce stigma as well. What I'd like to do now is take a 5-minute break for folks to take care of whatever business they have to take care of. I'm going to be fairly strict about returning right at 20 after 3 Eastern Time. And I will remain on the line, though, to take questions for anyone who would like to post them now.
And I'm also staying on the line if there's questions.
Okay, I'd like to go ahead and get started again. Can people hear me? Can someone enter a message?
And I wonder, Lauren, if you can hear me.
Yes, I can hear you, Rich. Okay, great. So I'd like to go ahead and start up again. Module 2 covers Opioids 101, and I know that people's audience backgrounds are fairly diverse. We do have some clinicians, some administrators, some managed care professionals as well, but because everybody potentially has varying levels of experience and knowledge, I want to get everyone on the same page in terms of concepts and terminology. So this may be a review for some people, but for others, it may be more of an introduction or things that you kind of knew but weren't really clear on and have been fuzzy on in the past. So I'm going to move fairly quickly through this, but I am going to pause for questions as well so that if this material is new for you or you need some clarification, let me know. The other comment that I'd like to make is that there are some slides here in this module which contain pictures of heroin, pills, and some other substances. Do what you need to do to take care of yourself. I will give you a heads up before those slides come on. They can be triggers for some people who may be in recovery themselves, so I want to give you that heads up, and I will notify you before those slides come up. Okay, so this next module is going to provide, again, this basic overview of opioids and opioid treatment, and it's going to set the stage so that in the subsequent modules we can actually see where buprenorphine fits into the treatment system and where it can contrast or complement other treatment modalities. The goals for this module are to go over opioid addiction in the brain, go over definitions of opioid agonists, partial agonists, and antagonists. And this is where we're going to start to get into some of the pharmacology of the medication. We're going to talk a little bit about opioid receptors in the body, and then touch on opioid treatment options before the next module, which will be on buprenorphine itself during the next session. So again, to get clear on terms, I want to first go over the difference between opiate and opioid. So an opiate refers only to drugs or medications that are derived directly from the opioid, from the opium poppy. Examples are heroin, morphine, codeine. Opioids are a broader term that refer to opiates and synthetically derived drugs or medications that operate also on the opioid receptor system and that produce effects that are similar to morphine. So examples in this case are methadone, buprenorphine, Demerol or meperidine, and fentanyl. So just in terms of basic opioid facts, all opioids work basically the same way, regardless of their derivation. And there are benefits to using opioids. They're just not used recreationally. Obviously, they're used for pain relief, for cough suppression, and to slow down or halt diarrhea. The bottom line is that you can essentially administer or get opioids into your system and your body through multiple channels. Opioids also affect the brain globally, lots of different parts. They affect autonomic body functions here in the brainstem, like regulatory mechanisms for breathing, for blood pressure, for pulse. They also affect the limbic system, the emotional center of the brain, areas that are responsible for feeling pleasure. And then they also can block pain messages, the transmission of the pain messages going from the body to the brain, and in turn essentially diminish or stop the subjective experience of pain. I'd like to also go back and talk for a couple minutes to review some of the opioid receptor-related terms. Basically, a receptor is a specific cell or spot on a cell where a specific molecule binds. So you can think of it like a lock and key kind of phenomenon. There are unique receptors for many different molecules, including ones that are specific specifically designed to be receptors for opioids. This is a photograph that they included of a PET scan. These are images that identify the location of opioid receptors in the brain in normal, healthy volunteers. And these PET scans are nuclear imaging tools that produce essentially a three-dimensional image or picture of the biological functions in the body, and people can use them to pinpoint disease states. This is an image of a single brain at different time intervals, and the concentration of colors, in particular the yellow, show receptors that are located in the limbic reward system, or the emotional centers of the brain. Okay, this is probably one of the most important slides to understand at this point in terms of the way that buprenorphine works. What we're going to do is graphically show the different types of opioids, whether they're prescribed medications like Vicodin or methadone, or illicit substances like heroin. The first type of opioids are what are called full agonists. And in this case, we're talking about things like heroin, opium, Vicodin, methadone, that fully activate the opioid receptor. So the molecule binds to the receptor so that the more you use, the more effect you're going to experience. And if someone continues to use, they're eventually going to experience overdose and maybe possibly death. The second type are antagonists. Opioid antagonists like naltrexone or naloxone fill up the receptors. They take a spot in the receptor like a lock and key and block the action of other opioids. So if the person has used an opioid agonist like Vicodin, the antagonist is going to knock it off that receptor site. It's going to replace it on the receptor, and the person will experience withdrawal. If the person is stable already on an antagonist and uses another opioid, it's going to block the effect, so the user can't experience the high. One way to think about this is, again, with a lock and key kind of metaphor. So opioid agonists, the orange line, work like having the right key to the door. You put the key in the lock, you turn it, and the door opens completely. With the agonist, it's like having the wrong key to the door. So you put the key in the lock, and the door remains locked, and it can't open. And since that key is already in the lock, no other key can be put into it, even if it's the right key for that door, until the wrong key is removed. So it's going to bind and bind tightly and sit there until enough time passes that it can come off those receptors. The third type, which is where buprenorphine falls, are called partial agonists. And there they sit in the middle. So to use another metaphor, we can think about that like a car. So you're flooring the gas pedal, and that's analogous to the orange line. You're going to get full effect and full power. The blue is like flooring the gas pedal, but the car doesn't move at all. And then you can think about the green as being you're flooring the gas pedal, but you're only getting up to about 35 miles per hour. So I hope that some of the two different lock and key analogy and the car analogies really help you understand the different types of opioids that are available. The opioid agonists, so again, we're talking about substances that are derived directly from the opium poppy. These are the drugs that we're also going to call opiates. This is the point where I want to let folks know that the next 4 slides do contain visuals. So if you need to minimize for a second, I'll let you know when we come back up. The first is opium. Another type of opioid agonist is morphine. We have some semi-synthetics also, which are derived from chemicals that are actually extracted from the opium poppy, and these can fall either into opiate or opioid categories. These include things like heroin, Dilaudid, Percocet, Percodan, and Vicodin. And I'm just going to show the last slide with the different types of heroin. On the left-hand side, we have the Mexican black tar heroin, which is mostly used in the western U.S. The right top picture is the South American white heroin, which pretty much dominates the heroin market east of the Mississippi River. And then the right hand on the bottom is the Mexican brown heroin. Okay, so that's going to temporarily conclude my visuals for a second. Heroin's been around for a long time. It was originally marketed under the Bayer label, actually, as a cough suppressant. So this advertisement here is from 1897. Sometimes it's difficult to read the fine print, but essentially it says, Bayer Pharmaceutical Products. We are now sending to physicians throughout the United States literature and samples of aspirin, the substitute for the salicylates, agreeable of taste, free from unpleasant after effects. Also, heroin, the sedative for cough, heroin hydrochloride, available in a water-soluble salt. You'll have to call for them, order a supply from your jobber. Obviously, we have moved far away from considering any medicinal uses for heroin. Okay, I have a couple more slides that contain visuals. I've got 3 more. First, opioid agonists. Again, these are going to include the Dilaudid, the Percocet, Vicodin, and then some of the synthetics. So these are substances that are synthetically manufactured. They're considered opioids because they're synthetic, but they're not opiates. So again, this is your Demerol, your fentanyl, Orlam, Darvstat, etc. And again, we have a final visual on those. Okay. Okay, so partial agonists. And this is where, again, we move into the buprenorphine category, the category that was the blue middle-of-the-road line on the line graph that we saw earlier. The buprenorphine medication comes in 3 different forms. Buprenex is the IV form, Suboxone and Subutex are both sublingual formulations. The buprenorphine-only tablet is marketed as Subutex. The Suboxone formulation contains both buprenorphine and naloxone, and I'll say more about that a little bit later. Both the Suboxone and the Subutex are administered sublingually. They are the only medication right now with FDA approval for the treatment of opioid addiction that is not Schedule II, so methadone is Schedule II. And only Suboxone and Subutex are approved. Using either of these medications for the treatment of pain can be done, but it's officially considered off-label use. Again, even though Buprenex and another opioid partial agonist, Talwin, are approved for the treatment of pain, they are not approved for the treatment of opioid addiction. Again, you can use medications off-label for purposes other than they were originally intended. However, due to laws related to addiction treatment, it is illegal to use Buprenex or Talwin for treating opioid addiction.
Lauren, if I can jump in there again.
Sure.
Certainly in my 30 years had, I think, 2 occasions where I've seen somebody given Talwin after taking other more pure agonists go into withdrawal. So you don't see it very often, and Talwin was associated with many folks getting hallucinations. So you probably won't see it, but it may be useful information for anybody who's around an emergency room or a hospital that it is a partial agonist, not a pure agonist.
Thank you for pointing that out.
It certainly has had many folks dependent also, which has more to do with cognitive effects rather than its qualities as a partial agonist.
Thank you. I think that is a medication that's not familiar to a lot of people.
Sort of from the past.
Yeah. So in terms of what the 2 different sublingual buprenorphine tablets currently look like, we see the Suboxone on top in orange and the Subutex or just the buprenorphine mono product on the bottom. It is also available recently in a film that is also designed to be taken sublingually. The goal by the manufacturer was to have the medication dissolve a little bit faster under the tongue. It reportedly has a more favorable taste, and one of the other benefits is that it's individually wrapped and it is child resistant. So folks who had children who were concerned about diversion or other access feel a little bit more comfortable having these individually wrapped packages. It is generally a one-to-one conversion, and between the pill sublingual form and the film sublingual form, and at least amongst some of my colleagues, the thought is that some patients are able to actually reduce their dose a little bit when they switch over to the film. Has that been your experience, Rich?
Yes, usually very close, like you said, maybe a drop less. But I'll throw in one thought here, and that though the big hope was that the film would allow for less chance of abuse or diversion, and I guess time will tell about that. It even has a unique identifier on the package as far as a numbering system. I have already been getting reports from judges or other legal officials that folks were using the film to mail in envelopes to other individuals, including in prisons. So,
oh, wow.
Like everything we deal with, there's always a somewhat crafty side to addiction and what kind of diversion or abuses can come of even the finest attempts at coming up with safeguards.
Thank you. So as we mentioned a little bit earlier, opioid antagonists are those substances that are going to block the effects of agonists. So two examples are naloxone, which is the same medication that's in Suboxone, the buprenorphine naloxone combination, and naltrexone. We are not going to do the small group exercise here, discussing the question of dependence versus addiction ahead of time, but I'm going to move right into making this distinction because it is important in terms of understanding medication-assisted treatment. Most providers use the term addiction to describe a pattern of problems that result essentially from continued use despite negative consequences. To keep this term distinct, we're going to use the term addiction rather than the DSM-IV term of dependence throughout this training, because we want to differentiate from physical dependence and the behavioral set of problems that result from use. So I'm going to be using the term addiction to describe the whole package here. The term dependence is used to describe the body's reaction to the presence of an addictive substance. So that is physical dependence on the substance. It is one symptom of addiction, but it's important to remember that addiction can occur with or without physical dependence. It is defined by the presence of tolerance and or withdrawal. And I want to look at the specific definitions of those terms as well. Tolerance is the loss or the reduction in the normal response to a drug or another agent after repeated exposure over a long period of time. So it deals with the body's adaptation to a drug or to a medication, and the idea being that with repeated exposure, the response to the substance lessens. So it takes a higher dose to get the same effect. Withdrawal, on the other hand, is another indication of the body's adaptation to a drug, and it occurs when the normal dose that someone has been taking is reduced or stopped, and the person experiences painful or uncomfortable symptoms, or the person uses a similar substance to avoid having those painful feelings. So, for example, using methadone or buprenorphine to address impending heroin withdrawal. I want to look a little bit at some of the problems that the DSM-IV identifies. There we go. So according to the DSM-IV, substance use disorders are occurring on a continuum. So the less severe form of the problem is called abuse and is again, generally defined as having repeated problems associated with the use. But usually, the individual is still at least somewhat functional in their lives. And as the problem worsens, the person moves on to addiction, or what the DSM-IV calls substance dependence, where their functioning becomes much more markedly impaired. And addiction is based on clusters of behaviors and physical effects, and is really defined as a maladaptive pattern of substance use that leads to clinically significant impairment or distress, as manifested by 3 or more of the following 7 symptoms over a 1-year period. One of the important points to mention with respect to bullet number 3 is that taking larger amounts sometimes creates some confusion, but is designed to speak to a loss of control over being able to moderate your use. And over time, the words over time are really meant to reflect longer periods than intended, assuming that these criteria are familiar to most folks in the audience. For clarity, though, I just want to review, again, how I'm going to be using terms during this training. So to avoid any confusion, addiction is going to be the term that I use to refer to the pattern of continued use of opioids despite pathological behaviors and other negative consequences. And dependence is only going to be used in this training to refer to physical dependence on the substance, as manifest by tolerance and withdrawal, like we just talked about a moment ago. Okay, now that everybody has a sense of which drugs and which medications are included in the class called opiates, I'm going to look quickly at how they work. Again, I'm assuming that every this is going to be familiar to you all, so I'm going to move through it quickly. We know that overall opioids work by stimulating the opioid receptors in the brain and in the GI tract. And when they bind to a receptor, people experience relief from pain, cough suppression, feelings of euphoria, and sometimes, very often, stupor. So if the dose is high enough, they're going to also experience a slowing of respiration and potentially to the extent of death. Essentially, they're going to slow everything in the body down. The acute effects of opioids, obviously constricted pupils, constipation, sometimes an allergic kind of reaction that's accompanied by itching or difficulty breathing, and then lower libido also due to decreases in the sex hormones. As everybody knows, with chronic use, you can have even more significant symptomatology of these becoming much, much more pronounced. You can also see cross-tolerance. So once you have tolerance for one substance, like heroin, you'll have a tolerance for other opioids as well, like codeine or Demerol. And if the person is receiving treatment with, say, an opioid medication for medical purposes, the dose is going to need to be adjusted depending on their level of tolerance. Essentially, the other possible acute effects of opioid use, you're going to see a rush, generally reported to be stronger with injection or smoking and not so much with oral administration. The flushing, dry mouth, heavy extremities, drowsiness, nodding out, other cognitive impairments, slowing of heart rate and breathing. In terms of consequences of opioid use, again, these are familiar to you all: addiction, overdose, death, other medical problems and sequelae related, in many cases, to injection drug use. Heroin withdrawal specifically can be a little bit different than, sorry, I lost my train of thought. Can be a little bit different than the opioid withdrawal, other opioid withdrawal symptoms. Basically, everything in withdrawal is a rebound effect. So anything that had been depressed or slowed down by the opioid suddenly are going to emerge again. So you're going to see the flip side of all the symptoms that you saw when you were actively taking the opioid. So, for example, people get constipated when they're taking opioids, and then they have diarrhea when they're withdrawing. Again, as one of my patients in Baltimore used to say, withdrawal, it's leaking and the freaking. So it's essentially the watery eyes, the runny nose, the GI symptoms, as well as the restlessness and the anxiety and the irritability. If you notice the term goose flesh, this is, of course, where the phrase going cold turkey comes from. Some of the more protracted symptoms that can come from withdrawal from other opioids include the deep muscle aches, the insomnia, poor appetite again, the sexual side effects, depressed mood, and then, of course, drug cravings. Anybody who takes opioids for a period of time is going to develop a physical dependence. So somebody who's taking Vicodin for a period of time, even for pain, is going to experience withdrawal symptoms if they suddenly stop. This doesn't mean that they're addicted. It just means that their body has adapted to the medication. And usually the prescribing practitioner is going to help the patient gradually taper down on the dose once the medication is no longer needed. But if the person has developed an addiction to opioids, that's that they've lost control over their use, or they've developed problems associated with addiction, it's unlikely that they're going to be able to stop using without some type of adjunct treatment. So what I'm going to talk about next is really examining the treatment options that are available for people in the case of opioid addiction. Basically, we know that pills don't teach skills, and you need to continue to focus on changing thinking and living life on life's terms, and that's really where the rest of the treatment modalities and the rest of the treatment team come into this picture. They really help provide the rest of the long-term recovery picture, for both the initial stabilization and helping folks get started, but then being able to sustain that recovery. So again, that's going to include not just pharmaceutical treatments, but the rest of the mosaic of psychosocial and counseling services to really help people restore a degree of normalcy, not only to their brain function and their behavior, but then also to their employability, their reducing criminal behavior, lowering their risk of HIV or Hep C, and other diseases and medical conditions. The goal is really to combine both treatment approaches and tailor treatment so that it meets the particular needs of the patient. So whether that's deciding between inpatient and outpatient, behavioral or pharmacological, or some kind of combination of all of those. So one of the first ways that you can treat opioid addiction is through medication-assisted withdrawal. So the person is systematically, intentionally, carefully withdrawn from addicting drugs, and medications such as methadone, buprenorphine, clonidine can be used to alleviate people's withdrawal symptoms while they gradually return their bodies and their brains to an opioid-free state. And it can usually be done successfully in both inpatient or outpatient settings. Generally, a medical provider supervises this type of safe withdrawal and administers the medications to relieve those discomforts. As we know, this approach is not sufficient in and of itself to transition someone to maintaining an ongoing opioid-free life. Longer-term treatment modalities that help the person develop new behaviors and coping strategies is really critical. So people who are not successful in withdrawing or who choose not to withdraw from opioids should be considered for treatment with medications as part of the treatment plan. Second set of options are long-term residential treatment, for example, which provides a highly structured environment, including 24-hour care and lengths of stay that can range from 6 to 12 months. They also can use a variety of treatment models and modalities and philosophies, including therapeutic communities or cognitive behavioral therapy or any permutation thereof. The second set of treatment options fall under the umbrella of outpatient psychosocial treatment. So patients who are involved in this modality, continue to live in the community while they're receiving their treatment, and that allows them to continue to hold down a job and also use other social supports in their community. It does tend to be less costly than residential treatment. It varies, of course, in the type and the intensity of the services that are offered. It does tend to focus on group as opposed to individual counseling modalities. And medically assisted withdrawal is generally offered but is done with clonidine or other non-narcotic medications. And some patients report being very uncomfortable during the withdrawal process when clonidine is used, and consequently they may often leave treatment prematurely. Another set of modalities are behavioral therapies, which are designed to help people change their thought patterns around drug use and learn new behaviors to help them stop using and avoid relapse. And two general strategies have shown a lot of promise. Both contingency management is one of those, which helps the patient adopt new behaviors by reinforcing behaviors that help move them towards their recovery goals. So it can often include low-cost reinforcements like prizes or vouchers or clinic privileges that are delivered in conjunction with urine screening. And the research has shown that those can, in certain programs, help promote higher rates of treatment retention and abstinence as well. Another set of modalities are the cognitive behavioral treatment interventions, which really help the patient change the way that he or she thinks and behaves with respect to drug use and really just increase their positive coping strategies. There are lots of different behavioral therapies that have been used successfully. I'm sure you all are using those, including motivational enhancement therapy, matrix model, cognitive behavioral therapy, community reinforcement approaches, self-help, and 12-step programs. All of those are available options for our patients. Another way to treat opioid addiction is through agonist maintenance treatments. This is primarily, the best example would be methadone. So it helps stabilize people so they don't constantly experience those up and down cycles of use and withdrawal, allows them to function more normally, actually engage meaningfully in treatment, and diminish a lot of the negative behaviors that are associated with use. So again, this is offered in an outpatient basis, specifically in opioid treatment programs, and they've been shown to be most effective if they are combined with an effective behavioral treatment program. People, of course, may also continue to need treatment for other medical or psychological conditions and need to access a variety of support services, whether they are voc rehab, employment, education, housing, case management, parenting, socialization skills, or anger management. Everything that falls under that umbrella is really where the rest of the treatment team comes in. So to really go over the key benefits of methadone maintenance therapy, because again, we are not advocating that buprenorphine replace methadone, but just that it be offered as an additional treatment modality. Some of the benefits are that it has been used safely and effectively for over 30 years. If prescribed properly, it is not intoxicating or sedating. Its effects do not, again, if properly prescribed and taken, its effects don't typically interfere with ordinary activities, and it can suppress opioid withdrawal for up to 24 to 36 hours. As a final alternative, but one which is somewhat less utilized, is antagonist maintenance treatment. So again, this would be the blue line back on that line graph. And the best example would be naloxone. So as with agonist treatment, antagonist treatment is usually conducted through an outpatient setting. It's usually prescribed after medical withdrawal from opioids is complete. And if agonists are administered before complete withdrawal, the person can have precipitated withdrawal. So it's really important to make sure that all of the opioid agonists are out of their system entirely. They're going to block the effects of any illicit opioid, and so the idea being that over time this helps the person break the pattern and the desire for use. One problem, of course, with agonist treatment is that patients stop taking them because they want to get the experience of taking an agonist. So patients who are engaged in effective antagonist maintenance really need to have that positive therapeutic relationship with the treatment provider, ongoing counseling, and monitoring of their medication to determine their level of adherence. So in closing for this module, Again, the key points to keep in mind are that lock and key, a metaphor with respect to opioids attaching to receptors in the brain, causing pleasure, and after repeated use, the brain becomes altered, leading to the phenomenon of tolerance and also withdrawal. The second point is that medications that are operating through the opioid receptors, like buprenorphine, can prevent withdrawal symptoms and help the person function normally. But they need to be part of a larger package of treatment. That behavioral treatment is also important for addressing not only the psychosocial supports and life skills that people need to maintain recovery, but to also support management of cravings that can arise from being back in environments or situations that previously led someone to use. With that, we have a couple minutes left for questions. I would like to close and thank you all for coming to this introductory session for buprenorphine. I know that many people are hungry to learn about buprenorphine and learn about its specifics, and sometimes it can be a little bit difficult when you're eager to sit through a lot of this introductory material. So I appreciate your patience. I think that this has set a good foundation historically and politically and pharmacologically for the next modules, which we will address during the next webinar. Those are Buprenorphine 101 and identification of patients who are appropriate for buprenorphine treatment. So in Buprenorphine 101, we'll cover the development of buprenorphine. We'll compare differences between the combination product, the Suboxone, and the mono product, which is the Subutex. And we'll examine how you can use buprenorphine during various phases of opioid treatment. So how it can be used, how it is used during induction, maintenance, and then medically assisted withdrawal, the three different ways that it can be used in treatment. In the second module that we'll do in the next webinar, we're going to talk about the patient selection process, who's appropriate for buprenorphine, talk about the concept of opioid addiction and diagnosis, and then understanding the different patient characteristics and profiles that would make someone an appropriate candidate for buprenorphine treatment, but also for office-based treatment. So with that, thank you again, and we have just a couple minutes for questions. If for some reason your question is not able to be answered, we do have a record of those questions, and I would be happy to answer those after the session, either via email, or we'll take some time at the beginning of the next session to answer those. I've been taking notes of your questions along the way and plan to follow up during the next session. Thank you.
Okay, thank you very much. I'm going to put this back to my screen here, and we do have a couple questions if you'd like to go over those now, or would you rather wait for the next session? Sorry, people, I'm trying to get my questions.
No, I'm able to stay and answer questions. Rich, are you able to stay?
I too am able to stay.
Okay, great. Well, one of these, let's see, one of these actually is probably geared more towards you, Dr. Silbert. It says, hello, I'm a private practice LCSW who specializes in trauma and abuse. As you know, many abuse victims become addicted. My practice has seen many referrals for insurance company required therapy to get their Suboxone. Does CCBHO have best practice guidelines for accepting, treating, and working with this population? I've developed my own parameters for accepting clients, and thus far it seems to be going well. Do you require CAC credentials? Yeah, this is a question from Pennsylvania for all those people out of state.
Okay. It's a complex kind of question, so I'll give just really the short answer. Different regions have developed some of the basic requirements, and for instance, in the north central counties, they're very close to putting out a much more a comprehensive performance standard guidelines. So I think we're going to see more of that as time goes on. And basically, I don't recall requirements that psychosocial or therapy treatment be only by a CAC, even though that's very common. I don't think there'd be any problem. For instance, as a psychiatrist and somebody trained in therapy, I often did some of the psychosocial efforts right in my office while prescribing buprenorphine. So I don't think it's a specific requirement for CAC and in the standards that I've seen. If you want, we could kind of follow up on that questioning and you know, through the emails get a more comprehensive answer.
Okay, thank you. Here's another one. There doesn't seem to be a plan or organized way to titrate clients off the bupe.
And again, I think that's something, you know, in the upcoming modules we should cover, and there's a lot of controversy and consensus that still needs to be built in the literature and from science about that, because it sort of assumes that for sure it's a good idea to do that, and that'll require some more discussion on all our part in these modules.
Okay. Let's see, somebody has a comment here that several agencies are blending methadone with other levels of care with good success. Many treatment facilities are resistant to this, however.
Absolutely, and I would hope to see in the future that whether it be buprenorphine or methadone, that there is more blending, just like our program today talks about blending, but blending of the approaches to and tracks for individuals kind of meeting their specific needs. Right now, many providers, many facilities are against that for some of the reasons early in this module Lauren had already covered. Many people feel that any treatment other than a total abstinence treatment is somehow sinful, and many of the myths have stopped treatment centers from considering this.
Okay. What are some of the medical concerns for pregnant women taking Suboxone versus methadone?
Lauren, is that something we would cover in the other modules?
Yes, it is. And it is covered in 2 of the later modules, and I know is a major concern for treatment facilities that predominantly serve women. We are going to be covering those, and I will make sure that I have some updated information because I know that the slides are a little bit, the slides on the pregnant.
It is something
that pregnant women are a little bit behind.
It is something that can.
Innovation, so we'll have updated material for you on that.
Absolutely, and it is something that can be considered, but I think we should talk about that at more length.
Okay, and I just have 2 other questions here. Do you have any information on also using EMDR for helping patients deal with cravings?
I have to turn that one back over, Lauren, in case you do, because I don't right now.
No, I don't either. I'm most familiar with use of EMDR in other anxiety and PTSD type contexts, but not in cravings. That's something that we can definitely poke around and dig into for the next session, though.
Mm-hmm.
And we can also take comments from other people who are more familiar with it, too. Let's see, and then the last one is, why is yawning a symptom of withdrawal?
I'll give a try, and then Lauren, you can jump in. I mean, there's been different theories about that, and one is that in withdrawal, you're not getting quite the perfusion of your brain of oxygen or circulation you would otherwise, and it's a compensatory mechanism to try to overcome that. Other people have said that the yawning is something. I'm trying to remember the exact location in the brain. I can look that up. That may have had a center that was directly aggravated by the withdrawal process. I know, Lauren, if you have something else, but I mean, otherwise.
No, I was going to offer the same oxygenation perfusion explanation. I wasn't aware of the second one.
Right, I have heard of the alternative that it's pretty hard to study because to get live individuals to submit to having their head opened up to study. Kind of tough, but that's by my two understandings about direct central stimulation of a center there versus the perfusion issue.
Okay, well, that's it for the questions, so I guess we can close this session out, and I will send everybody the slides tomorrow, and they can look out for the next two modules a day or two before the next session.
Very good. Thank you all for joining us.
Very much.
Again.